This is the MyHeart.net podcast. This show is produced by Dr. Philip Johnson in conjunction with VitalEngine.com. Please welcome your host, Dr. Alain Bouchard, of Cardiology Specialist of Birmingham, Alabama, at St. Vincent's Medical Center, part of Ascension.
Welcome to MyHeart.net, and today we're going to talk about the transforming type 2 diabetes care, what patients should know. And we're going to try to talk a little bit about what is a type 2 diabetes and how do we treat it, how the treatment has changed. And we're going to try to describe maybe an example of a patient that presents to the office with type 2 diabetes, and we'll ask the expert, how does he handle it and how does he approach that type of patient? So with us today, we have the honor to have Dr. Tim Garvey, who's professor of medicine in the Department of Nutrition Sciences at the University of Alabama at Birmingham. He's also the founding principal investigator of the UAB Diabetes Research Center, and he's been doing that since 2008. So, Tim, thank you very much for taking the time and being here for us on a rainy day.
Well, it is a rainy day, Alan, but thank you very much for this invitation to join with you today and your audience as well.
Thank you. So let's start with the beginning. We know that the prevalence of diabetes is very important in the U.S. We calculate that approximately 38 million people have diabetes, 90% of which have type 2 diabetes. So this is where we'd like to kind of focus a little bit. Let's go over some definition. What is type 2 diabetes? How does it compare to type 1 diabetes? And are there some patients in between?
Yeah, well, let's just begin with the type 1 diabetes, which is more straightforward. This is a disease caused by autoimmune degradation of insulin-producing islet cells in the pancreas. And over a short period of time where this inflammation is ongoing and these beta cells are dying, the patient becomes, they must take insulin. There's insulin requirements here in order to prevent diabetic ketoacidosis and to stay alive. So that's type 1. It usually occurs in adolescence, childhood, early adulthood, but really can occur at any age. We used to call it juvenile onset diabetes, but we now call it insulin-dependent diabetes or type 1 because we know it can occur at any age. Now, type 2 diabetes, we used to call adult onset diabetes, can also occur at any age. In fact, we're seeing more of this in children. The majority of these patients, 90% are obese, have obesity, and this type 2 diabetes accounts for about 90% of the diabetes, so it's much more common. It's a little bit more complex. It's pathophysiology. It involves insulin resistance in the body where tissues cannot respond to insulin as well as they should, combined with defects in insulin secretion, where the beta cell becomes kind of resistant to the ability of glucose, of sugar, to induce insulin secretory responses. So the patient doesn't have enough insulin, and the insulin that is there doesn't work as well because of the peripheral tissues are resistant to it. And so the blood sugars rise. These patients do not require insulin to stay alive for the most part, although many patients can require insulin to control the blood sugar, to control hyperglycemia. And both of these forms of diabetes place the patient at increased risk of complications, particularly the microvascular complications that affect the eye and the kidney and the nerves, but also macrovascular, the larger blood vessels, which mediate, which is really atherosclerosis is what we're talking about here, that leads to stroke and heart attacks and peripheral vascular disease.
Now, sometimes I see some patients, they look like they would be type 2 diabetic, but they're actually type 1. What happens in those patients?
Yeah, this can be kind of tricky. And this really underscores the point that this is, even type 2 diabetes is a heterogeneous disease. There's various combinations of the insulin secretory defect and the insulin resistance. Some patients have more of one than the other. And patients where it's primarily the insulin secretory defect, they can behave almost like type 1 diabetics. They may need insulin sooner rather than later. There's a entity called latent autoimmune diabetes in adults, LADA, LADA, where there's also kind of loss of beta cells. And, we have to be careful when we follow these patients. And one way to kind of discriminate is to get C-peptide levels, fasting C-peptide levels. And if they're low, then we have to be that we have to pay more attention to this and consider that they may have either type 1 or a form of type 2 that's where the insulin secretory defect predominates.
Thanks. Seems like when I was training, and we're talking about in the 1980s,
Tell me
there
about
was
it.
there was not a whole lot going on with the treatment of diabetes. I mean, we had insulin since the 1920s. We had sulfonylureas in the 50s. And then we had to wait until 1995 when we started having medications like metformin that works at the level of the liver. And then it's like there was a floodgate, of new treatment with the TZDs, the GLP-1 agonists, the DPP-4, and finally SGLT2 inhibitors. So can you help us a little bit, kind of break down a little bit this alphabet soup of treatment of patients with diabetes? Very confusing to me.
Well, you're right. When I was doing my medical internship and residency, we had NPH and regular insulin. We had sulfonylureas. Metformin came along, and then we're dancing in the streets. We have this new medicine. But you're right. Then we had some insulin sensitizing drugs, the thiazolidine diones. The one on the market right now is pioglitazone, and that still can be a useful medication. We had the introduction of DPP-4, the whole incretin axis pharmaceutical area, including DPP-4 inhibitors, which prevent the breakdown of GLP-1 in the body and lower glucose through that mechanism, which we can talk about later. And then we also had giving actual GLP-1s to patients, GLP-1 receptor agonist to stimulate the receptor directly. And then you're right, we had the SGLT2 inhibitors come along. And now we have Mounjaro or tirzepatide, which is a GIP, that's a gastric inhibitory peptide / GLP-1 dual agonist. This one peptide that stimulates both receptors. So I guess it's a GLP-1 receptor agonist plus a GIP. So we now have this more full armamentarium, more arrows in our quiver, if you will, to kind of address this disease. I might mention that the evolution of these medicines, we used to just want to control blood sugar. That's what we ask of our diabetes medicines, to control blood sugar, hopefully with not too much hypoglycemia. Now we ask so much more of our diabetes medicines. It's not only do we want to control blood sugar, we want to do it without hypoglycemia. We want to do it without certainly no weight gain and even preferably some moderate weight loss. We want them to be cardioprotective, prevent heart attacks. We want them to be renal protective, prevent the decline in glomerular filtration rate and the emergence of albuminuria. We want them to improve congestive heart failure, prevent hospitalizations for congestive heart failure, and even address non-alcoholic steatohepatitis, NASH, which these patients are prone to, of course. And it's really treating diabetes in a broader pathophysiological context, and that is cardiometabolic disease. This one disease process with insulin resistance at its core that produces both metabolic and vascular disease. So we have to treat diabetes in this more comprehensive, holistic perspective.
I'm very glad you mentioned that because it seems like even when I was starting to practice in the 1990s, all we were focused on is about glycemic control or the control of the blood sugar. And with that, we could see that we could really kind of decrease the microvascular problem in the eye and in the kidneys. But it was very difficult and it was really very little effect on macrovascular disease problem like the heart attacks and the strokes and so forth. And so much so that in 2008, there was a lot of report on Evendia, rosiglitazone, that had apparently an increased problem with heart attack. And the FDA required, to have these, if we study new medication, we need to make sure that we look at cardiovascular outcome because, what do the diabetic patient die of? They die of heart disease. So I think there's been quite really a change, and a different emphasis in the treatment of diabetic patient now focusing a lot on whether the patient is at risk for heart disease or whether they have heart disease already. And for us at, focusing our treatment, on agents that do improve. And what are the main category of agents do we have, Tim, to really provide a decrease in cardiac mortality and decrease in heart failure?
Yes, well, you're right. These are earlier treatments that I mentioned, the sulfonylureas, metformin, insulin, the DPP-4 inhibitors. We now know through clinical trials that they're not harmful. But neither do they to protect patients against cardiovascular disease. They're non-inferior, if you will. But that's good. They're safe from that perspective. But now we've had some trials with the GLP-1 receptor agonist. We've had the SUSTAIN-6 and the PIONEER-6 study. That's subcutaneous semaglutide, Ozempic, and oral semaglutide, Rybelsus. These trials showed that these drugs had in diabetes had a cardiovascular benefit. The oral semaglutide in PIONEER-6, there were improvements, but it wasn't quite statistically significant. But the subcutaneous semaglutide in the SUSTAIN-6 trial was significantly cardioprotective. And now we know with even in non-patients without diabetes, we know that semaglutide, higher dose semaglutide for treating obesity can be cardioprotective, resulting in a 20% decrease in cardiovascular disease events. And these are in patients already on statins and already on angiotensin blockade for blood pressure. I mean, these medicines really look to me better than statins for preventing heart disease, because when the clinical trials with statins were done, we saw 20 to 30% reduction, but these patients, their blood pressure wasn't treated. There were no GLP-1 receptor agonists at that point. But at any rate, liraglutide, I should also mention, the Victoza has also been shown to have reduced these MACE events, major adverse cardiovascular disease events, usually taken to be a composite outcome, usually taking into account cardiovascular death, non-fatal MI, and non-fatal stroke. Any one of those prevents that composite outcome. So this is all good news. The final, the Mounjaro, the tirzepatide, the GLP-1 GIP receptor agonist, these trials are ongoing, so-called morbidity and mortality outcomes trial. So we'll have data there in the next couple of years. So, so we're really talking about cardiovascular disease there. So we know the GLP-1 receptor agonists are beneficial. Also had positive data with dulaglutide, Trulicity, along those lines. Now, these drugs, GLP-1 receptor agonists, can slow the rate of decline in glomerular filtration rate and the appearance of albuminuria. So they're renal protective. The other group of medicines, the SGLT2 inhibitors, and there we have, empagliflozin, Jardiance. We have dapagliflozin for SIGA, canagliflozin, Invokana, and erdagliflozin, Steglarto. These medicines have also been shown to be helpful with congestive heart failure, prevent hospitalizations due to congestive heart failure, and also to be renal protective, to slow the rate of decline in eGFR. And in fact, if you look at all of the guidelines, the evidence-based guidelines, whether from the American Association of Clinical Endocrinologists, from the American Diabetes Association, the European Association for the Study of Diabetes, across the board, these organizations are recommending the treatment with GLP-1 receptor agonists or SGLT2 inhibitors independent of hemoglobin A1C if the patients are at high risk or have heart disease, cardiovascular disease, or chronic kidney disease, or congestive heart failure. So that's a big change, okay? Yes, you can start with metformin, but if you have a patient that is at high risk of cardiovascular disease or has cardiovascular disease, consider GLP-1 receptor agonist addition. Um, or if they have chronic kidney disease or congestive heart failure, consider SGLT2 inhibitor addition to metformin, even if the hemoglobin A1C is under control, because of these additional benefits that these drugs have.
Well, I can see that, you've been treating diabetes for 40 years now, and it looks like the treatment keeps getting better and better. And probably you've changed, the way you treat, your patients with diabetes. I understand we have great medication. Obviously, lifestyle change is still your number one. I mean, we used to have like diabetic, nutritional teaching. Do you still do that, or do you adopt mostly heart healthy, kind of diet, Mediterranean lifestyle, and nutrition? Do you monitor the blood sugar, with the technology that we have now, like Libre and some other devices?
Well, absolutely. In type 1 diabetes, I can't imagine a type 1 patient with type 1 diabetes on insulin that shouldn't have continuous glucose monitoring, a CGM device. You mentioned the Libre, there's Dexcom, there's a number of different brands for these CGMs, continuous glucose monitoring devices. In type 2 diabetics, though, they're approved now, or you can get insurance coverage for them in type 2 diabetic patients who are also on insulin. I happen to think they can be beneficial even if the patient's not on insulin. The patient may have to pay for that out of pocket in some instances, but and these guidelines there's a lot of advocacy for broadening the use of CGMs in type 2 diabetes, even in patients not on insulin. They're very good at kind of looking, getting your average glucose, and now a target for glycemic control is the time and range throughout the day for good glucose control. In addition to hemoglobin A1C, in addition to fasting glucose. And that time and range you can only get with continuous glucose monitoring. So this has been such a valuable tool in helping us get better glycemic control and avoid hypoglycemia.
Well, we have the treatment of diabetes that has really evolved, but also part of this problem is we have pre-diabetes, a condition that is we have over 80 million Americans with pre-diabetes. What is your approach in these patients? I mean, first of all, can you define for us, what is pre-diabetes, and then how do we treat them?
Well, prediabetes, of course, is a dysglycemia that falls in between normal glycemia and the degree of hyperglycemia that is required for the diagnosis of diabetes. So it's kind of in between. But it's not a benign condition. For one thing, we know that atherosclerosis is accelerated. These patients usually have metabolic syndrome, prediabetes. They are insulin resistant. They're in the middle of the progression of cardiometabolic disease towards its end stage manifestations of diabetes and atherosclerosis, atherosclerotic heart disease. And we need to kind of pay attention to patients with prediabetes. And what are our goals? First, aggressive risk factor management. These patients should have LDL cholesterols below 100 in my estimation, based on, and even up down to 70 based on the Jupiter trial. Blood pressure control 120/70 using ACE inhibitors or angiotensin receptor blockers, ARBs. And what about progression to diabetes? That's what we have to pay attention to as well, because their risk of progressing to diabetes could be as high as 5% per year. So if they have obesity, the best approach is weight loss. And I know we're not going to talk about weight loss medications on this instance now, but we have new powerful medicines to get weight off of folks at a level, 10% weight loss is maximal for preventing progression to diabetes in these patients. So that's my target, is to get 10% weight loss. If they do not have obesity, and there are certainly patients with prediabetes that are lean even, of course, weight loss is not an option, but we have other things we can do. I like low dose pioglitazone, that's thiazolidinediones in those patients, like 15 milligrams a day. And of course, in both sets of patients, whether they have obesity or not, lifestyle is important. We know that a Mediterranean diet and exercise can prevent progression to diabetes independent of weight loss. So lifestyle is important as well.
We know it's a disease, a lifelong disease, but can we actually cure type 2 diabetes?
Well, no, you can't. The surgeons, like the bariatric surgeons, you get bariatric surgery, you lose a lot of weight, the diabetes goes away. At least there's normal blood sugars there. The surgeons like to call that a cure. But in actuality, I think pathophysiologically, it's better to look at it as remission. Because these patients, a chronic disease, these patients will always have a predisposition now to a deteriorating glycemia and the reemergence of type 2 diabetes, which occurs more often than not. So yes, these patients go into remission, but there's no cure. It's just like, we put patients with hypertension on antihypertensive, the blood sugar's normal, it's treated to target, doesn't mean they don't have hypertension. Patients with obesity, we can get weight off of them, but they still have the pathophysiological drivers towards weight regain. So they will always have obesity. It's a chronic that patients with asthma, they will always have asthma. It may get better over time, but they're always going to be at increased risk of bronchospasm from one allergen or the other. So it's just the way we have to view these chronic diseases. They require a commitment to lifelong management and follow-up, even if they're doing very well and it looks like all of the parameters of the disease are back down to normal, but they're at high risk of things deteriorating.
Well, Tim, thank you very much. I think we learned a lot. I mean, transforming type 2 diabetes and what the patient should know. And from Tim Garvey, professor of medicine at the University of Alabama. Thank you very much, Tim.
Thank you, Alan. It's been fun.
To learn more from our team of cardiologists, please visit us at MyHeart.net. You can also follow us on social media by searching MyHeart.net on Facebook and Twitter. And be sure to subscribe to this podcast so you don't miss our next episode.